like to welcome everybody to today's CSOHIMSS Lunch and Learn webinar titled Implementing a Successful Electronic Prior Authorization Solution. Our presenters will be Ms. Caitlin Graham, who is the Director of Provider Engagement over at CoverMyMeds, and Mr. Brian Kolligian, who is the CarePATH Ambulatory Team Lead Manager for Mercy Health. The handouts will be posted to the CSOHIMSS website. If you go to the Events and Education page, then down to Past Events, you'll find a link to the recording and all of the handouts for all of our past Lunch and Learn webinars and even all of our past conferences. Again, keep an eye on the CSOHIMSS YouTube channel. Just go to YouTube, search for CSOHIMSS. If you would like to contact CSOHIMSS, we have two email addresses, the csohio.president@himschapter.org. We'll go to our president and president-elect/VP. And if you email csohio.info@himschapter.org, that goes to pretty much our entire board. Most importantly is our webpage address, csohio.himschapter.org. Bookmark that and keep an eye on it because we do post information about all of our upcoming events. Everything we've got going on with the chapter, we try to keep that page updated. We also try to remain relatively active on social media, so hook up with us on Facebook, Twitter, and LinkedIn. On LinkedIn, we have a group. Just go to LinkedIn, type CSOHIMSS, and join that group. And we really want to take the time to thank our sponsors, because without the sponsors, we would not exist. We could not provide these educational opportunities in our conferences. So our sponsors are very, very important to us. Our top level sponsors are our premier level of sponsors, which we have listed here. We also, our next tier of sponsorship is elite, so we would like to also thank our elite level sponsors. So let's take a quick look at some of the upcoming CSOHIMSS events. Our next big event will be our fall conference. Now we're trying to finalize our date and time, but it looks like it's going to be the 3rd or 4th Friday in October. This one will definitely be down in the Cincinnati region. If you have something that you want to share, if you want to present, contact any of the board members and we'll get you what we call the Call for Speakers forms, which collects all the information that we must collect to provide CEUs to attendees. Now, these presentations must be educational in nature. They can't be a sales pitch. And we're looking for folks who have maybe an interesting project to share, or you're an expert in some field and you have something to share. The great thing about this is if you are a HIMSS member and one of your goals is to advance to a senior member of HIMSS or a fellow member of HIMSS, there's a certain number of presentation points that you must have, and presentations at chapter events or CSOHIMSS, the Lunch and Learn webinar series, count towards those presentation points you need to become a fellow or a senior member. In April, on the 25th, we will host our 11th annual Ohio Healthcare Information Technology Day. This is going to take place in the Ohio State House atrium. Keep an eye on the CSOHIMSS webpage for more information and as our agenda comes together. Then our spring conference is going to be May 18th. And again, we need speakers. This is going to be at the Conference Center at OCLC here in Dublin. Looks like we're going to be using that facility for our spring event every year because we're really happy. It seems they got a lot of space, food's good, so it's always a great event. So if you would like to be a sponsor for any of these events or you would like to be a presenter, please reach out to any of the board members. We do have some Lunch and Learn webinars scheduled. I'd like to share some information because we do these, we try to do them every month. We have missed a month here or there, usually around the Christmas and New Year's time. But our next Lunch and Learn webinar will be Wednesday, August 9th, where we're going to talk about eliminating facts for the sharing of clinical and administrative documents. The presenter will be Mr. Mike Hurley from OnBase. You do need to pre-register for these webinars. September 13th, Mr. Jim Garnham, who is from Eagle Dream Health, will be presenting on competing on analytics using data analytics to drive success under value-based payment. October, Crosschecks is going to present Humans at Scale, How AI Can Affect Your Organization. Now, November, December, need speakers. If you have a message you'd like to share, again, these need to be educational in nature. Reach out to me. My name's Scott Mash. Just go to the CSOHIMSS website, and you'll find, if you go under About and then Board Members, you'll find a link to my email address, or if you just email that csohio.info@himsschapter.org, I'll get that as well. And even out into 2018, we're trying to get all of our 2018 sessions scheduled, so if you have something that you want to present but you're not free until 2018, and let me know. I'll get you on the schedule.
All right, thanks everybody for joining us. I'm excited. I think we're going to talk about a really fun topic today. So I want to talk about implementing new technologies. We'll talk about some barriers, some best practices, and we have Brian here from Mercy Health with us to share a bit more about their experience implementing a new technology. And we'll dive into implementing the electronic prior authorization technology specifically, so EPA. Let's see. It's not letting me switch slides here. There we go. Okay. So we're going to talk about implementing a new technology in a provider setting specifically. So there are many reasons to implement a new technology, and lots of these reasons for electronic prior auth or EPA specifically. The first, streamlining the workflow. This is a big one because it saves so much time for providers and their staff. As with most technology solution, it also allows you to keep better records. So you can usually see notes or a trail of sorts of what has happened for any patient and any medication. And additionally, new technologies enhance your connectivity. So you no longer have to rely on archaic methods of communication, which also aids in the record-keeping piece. And of course, real-time insight into the current status of a prior authorization will only improve the experience for your staff and, most importantly, your patients. So implementing a new EPA technology doesn't need to be complicated. There certainly are things to consider when implementing any new technology, really. And while it might seem overwhelming or like a huge undertaking, it doesn't need to be. Doing some pre-work up front will ensure smoother adoption and a smoother rollout process. So I think most folks will agree implementing a new technology is important for those reasons. However, such effects can only be achieved if new technologies are used as intended. So over the next few slides, I want to dive into a study that was conducted by Biomed Central. The study aims to gain a better understanding of determinants influencing the success of the introduction of a new technology. And the study focuses on these determinants as perceived by nursing staff specifically. So while the study focused on nursing staff, the findings can really be applied to various healthcare roles. The study finds that when implementing a new technology, there are some determinants that we want to keep in mind. So the first is the innovation itself, and then the potential user of the technology, the organization, and any socio-political context that might come into play. And over the next few slides, I'm going to dive a little bit deeper into each determinant. So first, the innovation itself. Based on the study, based on the Biomed study, it's critical to involve users in the selection process of the innovation. So getting buy-in from those who will actually be required to use the technology is only going to help with adoption of that new technology. And it sounds simple, but the new technologies that were perceived by the user as easy to use are much more likely to be put into practice once that technology is available and live. Similarly, the technologies that were perceived as comparable to something that's currently working for that user, so a current process that they have, those technologies are also more likely to be utilized. So essentially, if the user can easily understand the process and relate it to things that they have in practice today, the innovation is much more likely to ultimately be adopted. And I'll talk a little bit more about involving the user a little bit later on. Which brings us to understanding that user of the technology. So if the user felt capable of working on the technology, unsurprisingly, they were more likely to adopt. The perceived support by management was also really key in adoption. So not only should the innovation get the user buy-in up front, but getting management buy-in as well shows increased adoption. The user feels supported in their use of the new technology, and they feel supported in their organization. The next is the organization. So in any organization, staff turnover or capacity for a new innovation, they're important to thoroughly understand. We often find that staff turnover can slow the process of implementing a new technology. We need then new user buy-in, sometimes new management buy-in, additional training, adoption efforts, etc. So those things are important to keep in mind as well. And then lastly, it is important to also keep in mind the socio-political context. So understanding any legislation that comes into play. For example, in the EPA electronic prior auth world, we often see various state mandates as a big factor for some organizations that we work with. You might think through if there are any company policies that might need to be followed. Are there upfront incentives or structural funds made available? If so, that could help boost the utilization of any new innovation. When looking at the process for a new innovation, we see it in 4 steps. So the first is dissemination, meaning every user gets access or they're supplied with the innovation. The second, at the adoption stage, the user then will develop their intention to use that new innovation. During the implementation stage, the user tries to use it in their daily practice. They get to experience what working with the innovation actually means for them in real life. And then finally, there's the continuation stage. So we're working on that innovation or that new technology. It just becomes part of their daily routine. In a recent study that CoverMyMeds did with an organization, SHC Universal, we asked how likely a user was to try a new technology. And the results were pretty positive. You can see most respondents were on the positive side. About 95% said that, yeah, they're likely to try a new technology. So I think that's good when looking at your organization and thinking about bringing new technology into play. But then we broke it down a little bit more. We wanted to understand the preferred approaches to learning a new technology. So how do people want to learn? And the top 2 answers were to tinker on their own or read the instructions. So I think this speaks to the importance of making the workflow or that technology easy to follow, and understanding what support documentation is available should be imperative. As you can see, most folks like to figure it out on their own between these 2 methods. Then we broke it down a little bit further, and we broke it out by gender. Same question, what best describes your approach to learning a new technology? And you can see similar responses between males and females. Males selected to tinker on their own at a greater proportion, but our top 2 methods of tinkering on their own and reading the instructions remain steady for both genders. Last, we broke it out by age. So while gender didn't see much of a difference, we do see a difference by age. The preference to figure it out on their own decreases as the user ages, while asking for help increases with age. So age is definitely something to consider when launching a new technology. Look at your users of that solution, include them in the solution selection wherever possible, get that buy-in from management so they have the support, and then plan the appropriate learning strategy from there. For those of you who aren't familiar with CoverMyMeds, we automate the prior authorization process for medications. We save pharmacies, providers, their staff valuable time, and we help ensure patients receive the medications they need to lead healthy lives a lot faster. So next I'm going to talk about the implementation process for electronic prior authorization specifically. Although the manual prior authorization process is outdated, it's tedious, and filled with overhead expenses, adopting the optimal electronic method can sometimes be challenging, just like adopting any new technology might be. So convincing pharmacies, providers, their staff to make a behavior change when implementing a new technology in their existing process can be difficult. At CoverMyMeds, we frequently see this when we're moving from the traditional paper, fax, and phone prior authorization process, moving someone over to the fully electronic prior authorization process and getting adoption there. And so while providers are growing increasingly wary of that outdated paper form process, the idea of implementing something new, albeit a better solution, it can sometimes seem intimidating. So I want to dive into a few ways we like to break it down to make that adoption process seem more manageable. So the first is doing a little bit of pre-work. When setting up for a new implementation, it's important to look at what needs done pre-project start. So create a baseline, a resource bank where people can go for help, and leveraging data are really key. I'm going to go into a little bit more detail on these points on the next few slides. So the first is creating a baseline. It's important to understand the starting point. It can help you be more scientific about the before and after comparison as well. And I think knowing what your current process looks like, and then use data wherever possible, you can then reevaluate after the new process is in place to better understand where you experience time savings, where you experience a reduction in turnaround time, whatever it is that you're measuring. It's important to identify those key success metrics early and then track them as you go and as you launch the electronic prior auth process or really any new process. So in the world of EPA, the mission could be to limit administrative waste in your health system, reduce prescription abandonment, things along those lines. It's imperative to understand what procedures the staff doing whatever this process is, if it's EPA, it's important to understand what they're currently going through to complete the process that you're attempting to streamline. Document pre-integration stats, time, financial cost, whatever else it is that you want to track. Next, create a resource bank. So understand how your staff will seek help. For example, if your staff is not yet comfortable with using the technology, they may not feel confident utilizing online resources to assist with that new electronic solution. One thing that we've done in the past that we found worked really well is we created printed guides for users to have as reference at their desk or at their workstations to help alleviate that barrier. Just a quick 1, 2, 3 step process on the main points that they needed to walk through the new integration. I think always have a detailed triage plan for user support when rolling out a new technology is also key. The user should know where to go for help. And then I think lastly, consider a phased rollout. So maybe work out some of the kinks with a controlled group or what we call a pilot. And that can also help kind of show you or guide how you roll this technology out to the rest of the organization as well. So you can see it in practice with a small handful of users and then build your training strategy from there. And when we talked about selecting a new technology a little bit earlier, we did talk about how important it was to include the user. And we see that theme again here when we're looking at the implementation process after the selection process. So getting that user buy-in, getting them involved gets the buy-in, and then you'll identify some internal champions for that new technology. Those internal champions could become the super users. They'll encourage others to adopt the solution as well, which is a big win in organizations when they've got that small group who really understand the ins and outs. And I talked about data. So I mentioned how important it was to get some good data in place so that you can compare the before and after, but be careful how you do this. Analysis paralysis can be a very real thing, and there are likely many different metrics you can show, and with that much data it can be difficult to take it and share it with your users or with your management in a way that's going to portray the user's impact or that new technology impact. So be sure to translate these results in a way that's going to show the cause and effect of their work. Paint a real-life picture so that they can see where they made an impact and that management can see where that new solution made an impact. If you're implementing an EPA solution, for example, maybe share the number of PA requests that were submitted and consequently received a determination. I think this will identify the number of patients that were able to begin their therapy who might otherwise still be waiting for or potentially abandoning their medication. If you're working with an EPA vendor, for example, they can usually help identify some of these and help you track them as you go. In our experience, having a defined rollout plan prior to launch is really key to implementing a new innovation successfully. There are several pieces of the rollout plan that I do want to call out that we've identified as most important. The first is creating a project prerequisite checklist. This is going to help guide the team to ensure that every imperative piece of the process gets accomplished. Some key items might be completing any required documentation that needs done, or maybe if contracts are required, those get executed. Working with various teams, maybe IT, information security, make sure that the technology is approved, get buy-in from management, get buy-in from users, and then just in general, make sure all supporting tools are ready and were in place before go live. We find it's really helpful to put together a timeline for the solution. This just helps ensure that you've got the appropriate resources, the appropriate tools lined up when you need them. So allow sufficient timing for contracts if that's needed, some time to get the right stakeholders involved, plan for training, what's that rollout going to look like, and then set the go live date. So we think it's important to have this set timeline, and we found it's really helpful in our health system EPA launches, but add some flexibility just in case any unforeseen events occur. So if there's a deadline that you're trying to hit, maybe back it up a week or two just to make sure you've got a little bit of wiggle room in case you need to address anything that you didn't foresee popping up. In any new process, it's important to identify a project lead. This is a big one that we find is really, really helpful. This person should be the owner of the solution launch. So there are typically multiple teams within an organization that need to be involved. In managing those prerequisites, it takes some organization. Having one person to really own that is important. When launching an EPA solution, we typically see like a project manager or similar role in that lead spot. The project manager or project lead, they usually serve as the primary point of contact, especially if working with a vendor. This is really, really important. That vendor then has one person to go to make sure that we're on track. They usually become the internal champion of the solution. They can pull in appropriate parties when need to. They can help plan for the education from the new technology. And ultimately, that project lead will own the success of the launch. I mentioned they could help with training. I think the project lead can be really key when creating a training strategy. And in our experience, there's no one-size-fits-all for a training approach. It's important to look at various options, who your users are going to be, as I mentioned earlier, before you select the training approach that best fits with your organization. We have implemented multiple different types of training. I'll talk a little bit about what we've found is successful. The first is webinars, just like we're on right now. Webinars are a good option if your organization maybe needs some extra one-on-one time. They can be helpful for if there are new people that are getting added to the project or new people that need to be trained after an initial training. And they can usually be executed very quickly. So when we work with health systems that are going live with EPA, a lot of times they'll call us and say, hey, we've got a new nurse or MA that we need to train, and we can usually hop on the webinar that same day if it fits with their schedule. So webinars are really easy to work around your staff schedule. The next is on-site computer training or more side-by-side training. This is actually what we typically recommend for most organizations. We find it works best when learning a brand new solution, especially because you've got a solution expert there on site. Like I said, they're side by side with one, two, or a small group of users. And I think this approach is especially helpful for folks rolling out a solution department by department. So it's a little bit more hands-on and can be a little bit more pointed. The next, a little bit different, more of a presentation style training. So still on site, but I would say this one's ideal for larger groups or if you're launching to multiple departments at one time. It can really be anywhere from 6 up to 24 people, if not more, to make sure that we're walking through the highlights of that new technology. Train the trainer. This is also a good one for large groups. Sometimes we might do a larger presentation training, as I mentioned on the last slide, but then more closely work with a small number of super users. And those super users can then train their colleagues on the solution. So if you're launching to a large enterprise, this might be your best bet. That way we can still get on site, we can get in front of a lot of folks, but we've got that smaller group who's really immersed themselves in the process and can help get everybody else trained. So just a couple general EPA implementation tips, a quick summary and a couple new tips here. So first is, if I haven't mentioned it enough, engage the subject matter expert. Find out what the current PA workflow is prior to implementing or to selecting the new solution. Make sure you're getting one that fits best with your organization. Identify super users. Set those roles early in the process. Creating champions for adoption, and they can become go-to people for troubleshooting if needed. Create a communication plan. We want all users or all parties to be aware of those changes. So for PA, we find it might be helpful to let the prescribers know that it's coming so that they might be aware of something new popping up in their EHR. Have a well thought out training plan that touches all or most of the users of the new solution, and establish a pilot or that control group that I mentioned. Not only can that help troubleshoot early on, we can make sure we get any kinks worked out, but then that can help your team pull together a more comprehensive training plan and maybe pick the best training plan for your enterprise. And lastly, I didn't mention this before, but I do want to touch on this. Consider a centralized PA department. So with the centralized PA department, you can have a smaller team or maybe one office, 1 to small group of users dedicated to completing the PAs needed for your patients. This makes them a pretty fast expert on the solution. They know the ins and outs of the process, and then they can relieve the burden from others in the practice. It establishes solution pros who can quickly and easily navigate the process. If they're in it all day, every day, doing these prior authorizations, they're going to be very efficient at the process. Whereas someone who's maybe doing prior authorizations for 1, 2, or a small group of prescribers Maybe they have a couple that pop up every couple of weeks, so they're not really in the solution as often, and it might be a little less efficient to get them in it and doing those prior authorizations less often. Using those implementation tips, having a checklist helps keep the project on track. So identify what needs done and at what stage it needs done. If you're working with a vendor, they can usually help create these project materials for you, and have a dedicated project lead. That project lead is going to be key to make sure that we're getting everything that we need done on these checklists. So these slides just serve as an example of a project checklist. It's identifying the stage, what needs to be done, who owns that task, and when it needs to be completed by. All that, again, if you're working with a vendor, they should be able to help walk your organization through this planning process, training, and everything else. They can recommend an appropriate training plan, project stakeholders, and they likely have resources already in existence that they can share with you. Now I want to turn it over to Brian with Mercy. He's going to discuss the specific project implementation that they did with CoverMyMeds for EPA.
Thanks, Caitlin. Appreciate it. Next slide, please. So as Caitlin mentioned, I'm going to go into just a few more details of what she already touched on in regards to what we did from an implementation standpoint. So we worked very closely with CoverMyMeds in order to come up with an implementation plan. Obviously, they have background and have done it before. So we worked with them in regards to what was within our current timeline, competing priorities, in regards to what we're working with, in what worked best for our organization in regards to rolling out. From a timeline perspective, you know, that's where CoverMyMeds had the expertise to know how long it should take to implement the project within our EHR solution, Epic. And then, you know, they work to customize a project plan with us alongside what we're working for. Next slide, please. Some of the best practices that I'd like to call out, what we did on ours is from a utilization of CoverMyMeds, defaulting in CoverMyMeds as a payer. So obviously from an EPA perspective, the payer and the formulary generally drive what is going to require an electronic prior authorization. So from a payer perspective, if we default in CoverMyMeds, CoverMyMeds does all the legwork. And essentially, CoverMyMeds will then take the demographic information that has the insurance information already on the patient's chart, use that within their database to pull the insurance information for that patient in the background, versus the end users having to try and you know, flag and make sure they have the correct insurance information on the patient's chart prior to entering the medication. Another point I want to call out is sending the prescription to the pharmacy when it was signed. So we wanted to make sure that we didn't hold up patient care. Say maybe there was a false positive in which the system and the formulary may not line up correctly, and they are saying there's a PA that's required. And if that PA technically may not have been required, we didn't want to hold up care. So we sent our prescriptions electronically to the pharmacy upon signing, even if a PA was requested. For our instance, we did a small pilot of around 30 to 50 MPIs, providers, ran it for about 4 to 6 weeks. And then, you know, we used that data to then determine out our full rollout plan. So for that pilot, CoverMyMeds was available to assist on site. They actually had people in our offices to assist the providers and clinicians with their workflows, and they also had technical resources on site in our home office in Cincinnati. And so from a pilot perspective, we did 30 to 50 MPIs, and then slowly drug that out a little bit longer due to some competing priorities, and ended up to around 100 providers before we fully rolled out. Next slide, please. So adoption strategy, again, I talked a little bit. Mercy Health is a large organization, so we have 7 regions that we support. So we did want to stagger that out. What we did is we worked with CoverMyMeds in order to pull data from the CoverMyMeds portal, and we targeted our highest utilizers of the CoverMyMeds portal and decided to use them as our target audience. So we took those highest utilizing users in our one region, had them be part of the pilot, and then got feedback and information from them. Also, got the kinks out of the system in regards to a technical standpoint, and then went live with one region at a time. Roughly, I think our first large region that went live was around 400 providers. After that, we coupled some of our regions together, anywhere from 300 to 600 providers in each one of those regions. To, as of earlier this month, we are now live in all of our employed practices. We have roughly 2,000 plus users throughout Mercy Health that are utilizing the system here. We worked to, from a training perspective, what we did is we tried to stay away from the classroom side of things. Obviously, classroom training, I think, is one of the best training that you can put together, but knowing from a time perspective, not everyone has the time to partial out and spend it in the classroom. So we work closely with our training team and CoverMyMeds to put together a recorded webinar. We also created a tip sheet and met with regional leadership. So we put together live webinars as well. Met with the practice managers of the regions, also met with our high-level leadership as well to get their buy-in, let them know what was going on, and did our best to communicate and have an understanding of what was going to happen in regards to that. We also worked closely with our training team as well to make sure from a support perspective that as they were rounding in offices, they were comfortable with answering questions from that aspect. And one item I would like to point out is that from a provider perspective, our providers obviously want to be more efficient. We want them to document more within the system without having to do more in the system, if that makes sense. So the biggest sell on this was that from a provider perspective, there were no additional clicks in the system. So the provider gets notified that there's a prior authorization required, but the clinical staff is the one that is actually filling out the form once it comes back from the insurance company and CoverMyMeds. Next slide, please. So some of the results. So here's our turnaround time. So in the gray in the background is our portal usage for CoverMyMeds for Mercy, and then the orange in the forefront would be when we went live with it from a pilot perspective and grew in regards to the workflow within Epic. As you can see, the turnaround time from a determination standpoint for the PA is significantly lower for those that use the workflow within Epic. We were actually down to 9 hours at one point last year in December. Next slide, please. Request per MPI, as again, the portal is gray, the Epic usage is in orange. As you can see, the portal steadily, or the portal stays about the same with a slight decline, and then you can see our Epic usage is increasing and dropped off a little bit, but stays steady as they continue to use the portal, or I'm sorry, as they continue to use the workflow within Epic. Next slide, please. And then last, Epic submission rate. So as you can see, as we went live and continue to grow with those providers that are on the system, we continue to see an increase in our submission rate through Epic in regards to using the electronic prior auth. Next slide, please. So here's a list of references used for the presentation today. They're available for download in the handout section here, and I believe there may be an email that gets sent out as well. And I will open it up or send it back to Scott, I believe, if he wants to read some of those questions that we have.
All right, let me pull up the question box here. Okay. First question, sometimes a user might not be a technical user, but want to try to understand the underlying technology. So how do you bridge the gap for a non-technical individual when trying to get them up to speed and understand the CoverMyMeds solution?
Sure, I'll take
Brian,
it.
I can.
Oh,
Brian.
Go ahead. We both want it. We'll probably have two different perspectives, so I think we can both answer it. But the first I would say is I think for users who aren't as maybe comfortable with new technology, the training is going to be key, specifically that side-by-side training, because that way we can help walk through specific examples that pop up. Likely they're doing prior authorizations today. If they're brand new to the prior authorization process completely, we can help kind of paint a picture of what the process usually looks like, and then work really, really closely with them to make sure they feel confident. We've had that that experience in the past with new users to really the CoverMyMeds technology specifically, and we find that with just a little bit more hands-on, they're really able to adapt it pretty quickly. Brian, do you want to add anything to that?
Yeah, agree on all those points. I think the other thing to note too is what we educate a lot of our users on is that the paper form you used to get off the fax machine is the same electronic questions that you answer within the system. So the questions aren't changing. The information that the insurance company typically requires is not changing. All we're doing is taking a paper process and putting it in electronically.
Great point.
We've got a two-part training question. First part is at what time is a good time for training prior to the product launch? And then second part, how do you ensure that new employees receive the same or equivalent training as those that were involved in the original project and rollout?
Mm-hmm. Sure. I can chime in on that one first. So I would say we've tried this a couple ways in the past on when to train new users. And what we're starting to lean towards is training the new users on that solution after it's live. So we'll push it out to make sure everybody has it, maybe even just a couple of days afterwards. We'll then conduct trainings. We find that that way they've got some examples of prior authorizations that are ready to be worked, and we can help them work through their real-life examples rather than if we're training maybe the week before. It might be a week before they actually see the process in their workflow, and they might forget everything they learned. But if it's live and if it's ready to go, then as soon as that training is over, they're able to adopt that new technology right away. For new users coming in to the new process, I would say it depends on the training strategy that health system went with. One of the things some of our health systems that we work with do is they'll offer maybe like a monthly or bi-monthly webinar for any new users that haven't seen it yet, that are going to be using the new technology. That way we can still do that very pointed hands-on training. And then the other option, of course, is the train-the-trainer model. So that organization might have a couple super users. I know Mercy has a lot of really great super users, and they can kind of head the training for any of the new employees that come in. That way it's very scalable.
All right, next question. Can someone address how the EPA solution integrates with payers? And this is both commercial payers and your governmental payers, Medicare and Medicaid.
Sure. So for EPA, majority of payers making up most of the patients in the U.S. are live with electronic prior authorization on their end, meaning they have the electronic question sets, can deliver them to you to complete or to the providers to complete, send back to the payer where they can review and respond electronically as well. And that is certainly the direction that the industry is moving. However, we are aware that not all payers are live with EPA today. And again, that's where we're moving, but it might take a little bit longer for some payers to become live. You know, maybe some Medicaid plans where their formulary is very tightly managed. They could come live on EPA a little bit later, but I will say the CoverMyMeds solution wants to address that. So we've got all payers in one place. That way, whether the payer is live with EPA or they're still on a classic fax-based solution, you can still complete the prior authorizations in the exact same way and submit them to the plan, where they will then review and respond in whatever method they have, whether it's EPA or that traditional fax-based.
Okay, next question. How do you continue to monitor the new technology to facilitate improvements in workflow and enhancements to the software? From the CoverMyMeds perspective, we try to be really, really close with our users. So we have a pretty constant feedback loop. Anytime someone is live on the technology, we want to make sure we're getting their feedback as quickly as we can. So if there are certain changes that they would like to see, we right away start to see how we can make that a reality. Pretty much any change that we make to our solution
was probably a user suggestion at one point. So certainly, you know, we want to prioritize the ones that will make a bigger impact, but I would say the way that we keep up with that is really just communication with our users and hearing feedback directly from them.
Okay, next question. How can this process be adapted for those times where the pharmacy originates the PA process?
Mm-hmm. Yeah, that's a good one too, because in reality, while we're moving more towards that prospective PA process where the prior authorization is initiated at the point of e-prescribing, the fact of the matter is, for a long, long time, it has been mostly retrospective, meaning after the claim rejection at the pharmacy. Because if you think about it, to a provider or their staff, if they start a prior authorization and it's not needed, that's extra work that they didn't have to do. So a lot of them for a long time liked to wait to get that notice from the pharmacy saying, hey, you need a PA, then they could complete it from there. So one of the ways that we like to address that is integrate with pharmacies. So we've got integrations with majority of the pharmacies in the US where if the prior authorization for whatever reason was not started during the point of e-prescribing, we want a way to catch that. So the prescription will be sent to the pharmacy where we have a similar integration on that side. The pharmacy can decide to kick off the prior authorization through our integration and deliver it back to the provider to complete any questions that still need to be answered and send it to the plan. So we certainly see that that is a reality today where lots of times it's the pharmacy notifying you, and we want to make sure we can provide a solution for that as well.
Check one other spot to make sure there are no other questions. I think that's it. Brian and Caitlin, I really appreciate you serving as speakers for today's webinar. Thank you very, very much, and also to say that we truly, truly appreciate the sponsorship and the support we receive from the CoverMyMeds team. You guys rock. Thank you so much.
Thank you. Thanks for having us.
Yeah,
and to our attendees, thank you for attending today.